In this section entitled Neuro Pharmacology, we'll be talking about the central nervous system itself, as well as different types of medications that may affect it. This section is an introduction to neuropharmacology, and we'll be talking about some common neurotransmitters and the medications that affect them. There are many important neurotransmitters in the central nervous system. Some of them are listed here. Glutamate is considered to be the primary activating neurotransmitter in the central nervous system, while GABA, gamma-aminobutyric acid, is considered to be the most important inhibitory neurotransmitter. Other neurotransmitters have varying effects based on their receptors. There are many important neurotransmitters in the central nervous system. Some of them are listed here. Glutamate is considered to be the primary activating neurotransmitter in the central nervous system, while GABA, gamma-aminobutyric acid, is considered to be the most important inhibitory neurotransmitter. Other neurotransmitters have varying effects based on their receptors. Glutamate, again, is the most important excitatory neurotransmitter in the central nervous system. The activation of glutamate receptors can cause cation influx, again, which can cause depolarization, and increased likelihood of action potential firing in the cell downstream of the glutamate release. Some glutamate receptors are ion channels themselves, while others are coupled to second messenger systems. There are very few clinically used drugs that target the glutamate receptors. Some important receptors that we'll talk about are the NMDA receptor, the kainate, and the AMPA receptors. The NMDA receptor is the target of ketamine and PCP, commonly used drugs of abuse. Ketamine is sometimes used in anesthesia. These are all ionotropic receptors, meaning they are ion channels. Other glutamate receptors are metabotropic or G-protein coupled receptors. The NMDA receptors are, again, calcium channels. They're highly permeable to calcium. They are blocked originally by magnesium ions around the resting potential. However, when the neuron containing the NMDA receptor is depolarized by other receptors, then the magnesium leaves the channel and allow the calcium ions to flow through. These NMDA receptors are classically important for synaptic plasticity and are thought to be very important for memory formation. GABA receptors are divided into two major categories. Again, these are inhibitory neurotransmitters that prevent the downstream neuron from firing. The GABA A receptors are ion channels, and the GABA B receptors are G-protein coupled. GABA A receptors, again, are ligand-gated chloride channels. They are the targets of many medications, including general anesthetics such as propofol, some sedative hypnotics such as benzodiazepines, and some anticonvulsants such as phenobarb. This is a GABAergic terminal, meaning this is a neuron on top that is releasing GABA onto another neuron that contains the GABA receptor. These are the GABA A receptors because they're just depicted here as chloride channels. This neuron is having an action potential currently that's allowing GABA to be released, whereas this neuron, the postsynaptic neuron, would be inhibited because of the chloride entering the cell and causing hyperpolarization. The GABA receptor structure in general contains alpha, beta, and gamma subunits. The GABA recognition site, it's important to remember, is distinct from the benzodiazepine recognition site. GABA B receptors, however, are G-protein coupled receptors, which are the target of some muscle relaxants known as baclofen. The acetylcholine receptor family contains three types of receptors. These include the nicotinic muscle type receptor, the nicotinic neuronal type receptor, and the muscarinic receptor. These are so named because they not only bind acetylcholine, but either nicotine and muscarine as well. Nicotinic receptors and muscarinic receptors are very important because they can be involved in many different disease states. For example, antibodies against the muscle-related acetylcholine receptor are implicated in causing the disease myasthenia gravis. Acetylcholine release from the vesicles in a neuron is inhibited by the botulism toxin. Again, in myasthenia gravis, in which antibodies are attacking the acetylcholine receptor, those acetylcholine receptors are markedly diminished. Therefore, it is difficult for this neuron to activate this muscle, which is why these patients feel weakness. Dopamine is another important central nervous system neurotransmitter. Central nervous system stimulants such as amphetamine and cocaine are able to increase dopaminergic activity. And the way that they do this is by blocking the transporter that reuptakes dopamine from the synaptic cleft. And we all know that the loss of the neurons that release dopamine causes Parkinson's disease. Those nerves have their cell bodies, usually in the substantia nigra. Dopamine is another important central nervous system neurotransmitter. Central nervous system stimulants such as amphetamine and cocaine are able to increase dopaminergic activity. And the way that they do this is by blocking the transporter that reuptakes dopamine from the synaptic cleft. And we all know that the loss of the neurons that release dopamine causes Parkinson's disease. Those nerves have their cell bodies, usually in the substantia nigra. Dopaminergic receptors belong to 5 different subtypes. Most antipsychotic medications are antagonists at dopamine receptors. The dopamine 2 receptor has 7 transmembrane domains. It is a G protein coupled receptor. There are 2 different families of dopamine receptors, the D1 receptor family, which includes D1 and D5, and the D2 receptor family, which contains D2, D3, and D4. D1 and D5 work downstream by increasing the concentration of cyclic AMP through GS activation. D2 through D4 will actually do the opposite and cause decreased cyclic AMP through the G protein GI. Let's talk briefly about the norepinephrine receptors. These receptors have multiple subtypes that are found in several areas in the brain, especially the locus ceruleus, which is classic for having these norepinephrine receptors. These receptors are also the target of some stimulants and antidepressants. Serotonin, also known as 5-hydroxytryptamine, is important for binding its receptors as well. There are numerous different subtypes of serotonin receptors throughout the brain. All are coupled to second messenger systems, except 5-HT3, which is itself an ion channel. There's a great deal of pharmacology involved in serotonin in humans. The most important drug types we'll talk about are the antidepressants, specifically the serotonin-specific reuptake inhibitors, as well as some antiemetic drugs and migraine medications. Opioid receptors are very important as well in the humans. There are multiple subtypes. These are generally considered to be inhibitory receptors that are all coupled to second messenger systems. These have a role in the modulation of pain, and they are the target of opioid medications such as morphine. The human body also creates endogenous opioids to bind to these receptors. Cannabinoid receptors are also seen in the human and the central nervous system. Endogenous cannabinoids that are made in the human include anandamide. These are lipid-soluble compounds. Cannabinoid receptors are also G protein coupled. The way they work is by inhibiting adenylate cyclase. A lot of the signaling pathways, however, for cannabinoid receptors are very poorly understood. The drug of recreation, marijuana, contains an active component that is delta-9 tetrahydrocannabinol. This is the active component of marijuana that does bind to the cannabinoid receptor. It is able to persist in the body for days. Marijuana itself contains about approximately 1 to 10% THC by weight. Other formulations contain more, such as hashish. Marijuana itself is a Schedule I controlled substance, meaning it's illegal to be used. However, there are some states that allow its medicinal use in patients that have glaucoma or end-stage cancer. It has many physiological effects. It causes euphoria and relaxation, as well as analgesia in some patients. It can also prevent nausea and vomiting, and it's able to decrease intraocular pressure. Marijuana use is not known to cause prominent tolerance, physical dependence, or psychological dependence. It does, however, over time lead to central nervous system changes, such as lethargy. We'll talk briefly about sedative hypnotic medications. These include many different subtypes of medications, including benzodiazepines, barbiturates, and alcohols. In overdose, it's important to remember that these can cause respiratory depression and death. There are some older sedative hypnotics that are not used anymore, such as barbiturates and chloral hydrate, that are far more dangerous than the newer benzodiazepines. The mechanism of action of sedative hypnotic medications, especially the benzodiazepines, is to enhance the action of GABA at the GABA-A receptor. Remember, GABA-A receptor is a chloride channel. Benzodiazepines work by increasing the frequency of chloride ion channel opening. It's important to remember that GABA is required for benzodiazepine to be working. If you were to just put benzodiazepine next to the receptor, it would not work. GABA has to be present as well. Barbiturates, however, increase the duration of chloride channel opening in response to GABA. And to illustrate this, we have a cell here that we are measuring membrane potential. And when GABA is not present, you only see minimal opening of the chloride channel. However, when GABA is given, you see that the frequency increases of the chloride channel opening. You see 4 different openings here. If the GABA is given along with the benzodiazepine, you see increased frequency of opening, but the duration is the same, meaning these are very short duration openings. When a barbiturate is given along with GABA, you can see that the duration of the opening is much longer. The antidotes to benzodiazepine include flumazenil. This is important to know for USMLE Step 1. Flumazenil is a direct antidote for benzodiazepine. For barbiturate overdose and for other sedative hypnotics, there is no specific antidote. Benzodiazepines are commonly used for both sleep disorders and anxiety. Another important reason to give these medications is patients that are alcoholics and have developed delirium tremens. They can prevent a lot of the seizure-type activity seen in those patients. Relatively safe in overdose, they can be dangerous, however, when they're combined with other medications. Again, flumazenil is the known antidote for benzo overdose. Some specific benzodiazepines that you should know are alprazolam. Alprazolam is generally given for anxiety, panic, and phobias, and it can be used as an outpatient. It's relatively rapid acting, and it has a short half-life. Valium is longer acting, also known as diazepam. It's commonly given for anxiety and seizures. This one is also commonly given for delirium tremens or DTs. Klonopin, or clonazepam, is more often given as an anticonvulsant than other benzodiazepines. It can also be given as an anxiety treatment. Versed, which is another benzodiazepine, is more short-acting, meaning it's quick on and quick off. It's commonly given to patients that are undergoing sedation for a procedure. To talk briefly about barbiturates, these are medications that are older than benzodiazepines. They have multiple clinical uses. Again, for their role as a sedative hypnotic, these have been replaced by benzodiazepines. However, they are very important in some patients as anticonvulsant and anesthetic medications. These are very dangerous in overdose. This is why they have become less popular. There is no antidote to these medications. Another reason why barbiturates have become less popular is that they do induce the hepatic cytochrome P450 system. Phenobarb is most commonly the cause of induction of cytochrome P450. This can cause multiple drug-drug interactions. Barbiturates also induce an enzyme called delta aminolevulinic acid synthase, a key enzyme in heme synthesis, which is contraindicated in patients when they have hepatic porphyria. So barbiturates should not be given to these patients. Barbiturates are also a drug of abuse, more commonly than benzodiazepines. Chronic use can lead to tolerance and dependence. Also, sudden withdrawal of barbiturates can lead to severe withdrawal symptoms, including anxiety and agitation, as well as seizures and hyperreflexia. Chloral hydrate is an older sedative hypnotic. It is sometimes used in children for sedation prior to procedures. It's very dangerous in overdose, and there is no antidote. Some other sedative hypnotic medications that have become more popular recently are the newer zolpidem, zaleplon, and azopiclone. These are commonly used in patients. Some patients that have trouble sleeping will tend to use herbal medications to help fall asleep. Kava kava and valerian root are commonly used in teas. These medications are known to potentiate GABA-A. These are used both as sleep aids and anxiolytics. these can have additive effects with other CNS depressants, and kava has been shown to cause liver cancer as well as liver damage, and should be used very sparingly. This concludes our introduction to neuropharmacology. The next section will deal specifically with anti-epileptic medications.